Good evening, it's Jackie Kurta, and I wanted to give you a narration of the second PowerPoint. Many of you may have already viewed it, but this might give you an opportunity to kind of hear additional perspective on it, and then you always have it in its unnarrated version to go back and look at some of the information in greater detail. So this particular PowerPoint deals with a bit about the DSM, also populations at risk, a look at dual diagnosis and co-occurring disorders, some issues around the family addiction, and also a bit of a look at codependency as well. So here we go. The DSM-5, some of you may be familiar with. A lot of places have not quite begun to use it yet, but it's interesting to note some of the substantial changes that are coming down as a result of the DSM-5. Particularly, they have combined the categories of substance abuse and substance dependence into one single category that they're calling substance use disorder. And the defining characteristics are really measured on a continuum or on a spectrum and indicated as either mild or severe and areas in between. An interesting addition to the DSM-5 is a category on behavioral addictions. Particularly, they focus on gambling, though I think we can all acknowledge there are a variety of behavioral addictions, or what might also be called process addictions, that certainly can be added in there. To take a look at the DSM-4, and I think it's important to keep in mind what these definitions are, because in common practice, that's really the way that professionals in the field communicate about the level of distress or the level of functioning or lack of functioning with people engaged in either substance use or other behavioral patterns of addiction. So substance use, or abuse rather, with the DSM-4 is defined as a maladaptive pattern of substance use manifested by recurrent significant adverse consequences related to the repeated use. So failure to fulfill responsibilities, dangerous situations that continue to be engaged in, continued legal difficulties, law enforcement issues, interpersonal issues, social issues, family issues, and the use continues despite these negative consequences. If you look at addiction and dependence, according to the DSM-4 TR, it's clinically significant impairment or distress manifested by a set of criteria, and people, in order to essentially qualify for this diagnosis in the past, they had to have met 3 or more within a 12-month period. And these are issues, criteria that have, I think many of you are familiar with in the work that you've done, but we'll review them here. So tolerance, needing more and more of the substance than initially needed, withdrawal symptoms, and experiencing, significant cravings, physical and psychological. The need to use more and more of the substance over a longer period of time than was originally intended. So people who are attempting to sort of limit their use or define their use and are unable to do so. Attempts to quit or cut down that are unsuccessful. The amount of time spent in activities related to the drug or the substance or the behavior, occupational, recreational, social events that continue to be impaired as a result of the use, and these repeated negative consequences not being enough to keep somebody from using. So 3 or more of these defined dependence in the DSM-4. So in general, one would take a look at increased use leading to increased risk. And the risk potential is measured by a number of different factors. Certainly one of them is the frequency of use. So how often are people having to use the substance? The strength and potency of the dose of the substance, or the potency of the increased potency, essentially, of the behavior. How long somebody's been using. There's a great deal of research certainly about early use leading to greater chances of dependence. Half-life of the drug is an interesting one. Different drugs have a different half-life, and essentially the half-life is the length of time for the drug to metabolize in the system to half of the initial strength. So a drug like marijuana has a very long half-life and stays in somebody's system for potentially up to 30 days, where a drug like cocaine that has a very short half-life and leaves the system very quickly. That can actually lead people to use more frequently and lead to addiction more quickly. The way that people use drugs, and again, more and more, I think this is a very important consideration, because different ways of using drugs lead to different effects in the brain. So smoking being the fastest way that a substance gets to the brain. Although injecting substances can certainly be very risky and very dangerous, in terms of how it affects the brain, it's not nearly it's not as powerful as inhaling or smoking. So it's important to distinguish oftentimes with people, especially people using opiates, how are they using the drug? Because there are different risks, of course, for people who are injecting the drug, different risks and medical issues certainly that come into play. But the way that the drug is used can certainly be an increased risk in many ways. So indications of dependence or addiction. So there are lots of discussion about psychological versus physical addiction. In psychological, in the conversations that we have about somebody being psychologically addicted, we often find that what people are coming to understand or come to learn about their use is that they are not using for the effect of the drug. At a certain point, they're using just to sort of regain that feeling of being normal. The drug doesn't do anymore what it used to do for them. Now it just gets them to a point where they're avoiding the withdrawals and feeling what they consider to be normal. Physical dependence. Clearly, the body is then dependent on the drug to maintain a proper chemical balance, and if the substance is unavailable or not used, then these substantial withdrawal can occur, and the symptoms are quite powerful and in many ways well defined. So when somebody is experiencing an addiction or a dependence on a drug, there are some indicators that sometimes you can have great conversations with people about these things, just in a discussion about their drug use without naming it, labeling it, defining it for them. Just getting to know how they use the drug or what it means to them is a really great conversation. So what is their concern about having the drug or not having the drug available to them? Do they end up carrying the drug? Are they taking great risk at having it in their car, having it on their person, needing to have it at all times? Do they develop reasons to use at times when they know that it's unhealthy or dangerous? Are they using alone more than they used to? Do they change their social circumstances to be around people who are using more than other people in their lives? And what are the risks that they're taking to use this drug or to engage in this behavior? What risks are they putting themselves in on a regular basis? How important is it to them? Psychological dependence is an interesting phrase here that some people feel a lot of people feel it's quite a necessary step in the process of addiction. A physical addiction can often, be kind of just endured. Withdrawal symptoms can be endured, but a psychological addiction is a way more powerful condition to heal and treat. So addiction defined as a disease of the pleasure-producing chemistry of the brain. Here I think, that I've kind of gone through all these things, and you can take a look back on it again, but it's an intense craving, physical and psychological. What determines the potential for abuse in a substance or a behavior? The action, the rate of the substance. So as I said, how quickly the substance gets to the brain. And then how long the substance stays within the brain. So again, this is kind of the half-life concept. So how long the brain is affected by the drug can really determine the addictive quality. So nicotine is a good example. Nicotine, people who smoke are reinforcing this addiction, 20 plus times per day if they're a pack-a-day smoker. And that certainly increases the addiction potential. So a little bit about populations at risk, just having chosen just a handful of them here. Adolescents, we'll go into why. People with mental health issues, we'll go into that as well. People in crisis, more likely to turn to unhealthy coping mechanisms, things that may have worked for them in the past, and they gravitate towards them when they're in crisis or trauma. The elderly and dependent population, and certainly people with family history, more and more research showing that there's some genetic predisposition or genetic composition that leads to addiction. So let's talk about adolescents, college population. A lot of you deal with these students here in Santa Barbara or wherever it is that you're doing your traineeship, and adolescents, the teenage and even younger at this point. Here's the list, right? Stress, anxiety, depression, fear of failure, loneliness, the issues of boredom that they tend to face when they have to fill their time and aren't necessarily curious or creative enough to fill it in ways that are internal, so they actually go to the external to do that. Family pressures, academic pressures, issues of sexuality and gender identity, and just fitting in. All of these can be factors that I think many of you deal with in your traineeships, and I think are great discussions for young people around the risks and the temptations around substance use. Elderly population, again, many of you are dealing with that in your particular work and your studies at Antioch. People, the issues of cognitive impairment and attempts to kind of cure that with drug use, and the idea that people are abusing drugs, not even aware that they're doing so by not taking their drugs properly, forgetting to take their drugs, doubling up on their drugs by mistake, that kind of thing. Lots of depression, of course, loneliness, abandonment by people who no longer are in their lives or don't have the time, patience, or interest in being a part of their lives. And then there are some caregiver issues. Certainly, people who want to for lack of a better word, disable the elderly population, make it easier to care for them. Sometimes there's abuse issues where caregivers, intentionally or not, are over medicating the elderly or the dependent populations to kind of make it a little easier for them. Getting into dual diagnosis, also known as co-occurring disorders, also known as comorbid disorders. And the definition essentially is that these are mental health issues that exist in combination with a substance use disorder. So that's kind of the generally understood definition. I'm going to let you take a look at this on your own in the PowerPoint, but it's a fascinating look at the similarities between addiction and mental illness. Really take a look at this and see that in clients or patients who are dealing with mental health issues and families of patients and clients dealing with mental health issues, there are so many similarities between the criteria and the behaviors and the stigma and just the way people are in the world. And it's just a fascinating kind of look at the way these two things, issues coexist. ACOA, it's a common term for adult children of alcoholics. These are people who, as adults, are recognizing that they grew up in a family system or in a family dynamic where alcoholism or drug addiction or behavioral addictions occurred. And in many ways, the alcoholic family, or kind of using that interchangeably with maybe a family of addiction, and a healthy family are really at opposite ends of the spectrum in many ways. The alcoholic or addicted family stifles emotional, physical, sometimes psychological growth of its family members, whereas the healthy family would, there's a healthy outlook and a healthy orientation and a healthy differentiation in the family. One of the common factors in ACOA families is this issue of abandonment. It's very common, and it often gets expressed in ways that aren't named as abandonment. And I'll next slide or two, we'll have more information about that. But the abandonment is very often a physical one. Children are left alone by parents who are in their addiction, or they're left alone while parents are not supervising them properly. Their physical needs are often not met. Certainly we see this in circumstances that involve meth addiction or meth labs or meth houses, where the people under the influence can abandon their children and not physically take care of them, and emotionally equally, if not more devastating than physical abandonment, that although parents are physically present, they may not be emotionally present. And we find that in a lot of our clients who have grown up in families where they were emotionally, psychologically abandoned. It's a very profound experience. Sometimes the abandonment can translate into a fear of not surviving. They can't identify it, they can't name it, but often if they go through the process of talking about their family system and perhaps being in groups where others are sharing their experiences, this becomes a little bit more known to them. And these feelings of fear are so overwhelming that sometimes people unknowingly divert them into expressions of hurt or anger. The hurt is very deep, it's sad, it's lonely. People are afraid to express the emotion because they feel like once they open that up, they won't be able to stop it. It'll be a well that just is never ending. Or if they express anger, that they're afraid that their reaction will be such that they'll hurt somebody, again, psychologically or physically. So they control their emotions very deeply. They have a very tight rein over their emotions in order to not let it out for fear of what those consequences would be. This is just a bit of a matrix again. Abandonment goes into fear, and fear can be expressed in a number of in these ways, and probably many other ways. But this is just one example here. Characteristics interesting for people to look at in your counseling rooms, in your clinical rooms. That they won't always be expressed in the same ways, but these are some emotional and some mental or psychological indicators that therapists should just be aware of, because again, people won't come in naming what it is that they're experiencing, but through your conversations and through your clinical work, you can uncover some of these behaviors and perhaps relate it back to their family system dynamic. Again, similarly, some physical characteristics. We are holistic human beings, and there are very often somatic issues that people experience that can't be identified or can't be directly linked to a physical condition, but there's a deep psychological condition that keeps that ailment or that malady in place behaviorally as well. So good things to take a look at. I'd suggest you just go back and take a peek at these again. A lot of negative thinking, a lot of self-esteem issues. People growing up in alcoholic or addictive family systems very often do have a very profound sense of low self-esteem, and some ways to help people are use of affirmations. This is just a quick little idea, but there are many other ways to establish that trust with somebody so that you can begin to help them develop their self-esteem and their sense of well-being. Codependency, just a quick little bit here on codependency. There's a lot of information here that I'm again hoping you'll go back and take a look at, but we find codependency exists, again, on a spectrum. I think one of these charts here, I think if you take a look at this chart of codependent behavior, I think we all have aspects of it. Certainly when I take a look at it, I can, pinpoint, a majority of these things that I experience myself. It's a matter of it's a spectrum. Again, if, we all experience lots of these factors, it's how disabling or dysfunctioning it is in our lives as to whether or not it's problematic or just, again, an aspect of our life. So it's learned behavior. Codependency is witnessed and viewed and picked up as a learned behavior from parents to children and family members. It's a relationship addiction. Some people look at it as a relationship addiction, and it's certainly, a condition that can affect one's ability to have a healthy and mutually satisfying relationship. It can, I think, oftentimes the folks who attend the Al-Anon groups or part of the Al-Anon community recognize these behavior patterns as ones that really don't serve them well or serve their relationships well. You can take a look at this again. The term is a rather broad one. I think that it not only, at this point, relates to systems where there is addiction or substance abuse, but people can be, experience codependency in family systems that are just that don't have substance abuse or addiction in them. So it's a pretty broad term at this point. This is the list I was referring to. So take a look at this and just recognize that, again, these things exist. It's a pattern of behavior that's important. We all may find ourselves experiencing these behavior issues at some points in our life, but again, it's a pattern, a repeated pattern of behavior that keeps one or multiple members of a family system in a healthy, mutually satisfying relationship. How does it develop? What I mentioned, dysfunctional families don't talk about these issues, so these issues tend to sort of promote themselves over time. Family members keeping secrets, repressing emotions, and a lot of attention focused on the family member who is ill or addicted, and sort of a codependent relationship around that identified family member. And so these behaviors tend to kind of build upon themselves. These are some behavior patterns that you might see in clients or patients. And again, take a look at this when you can, just so that you kind of have these warning signs in mind when you're working with somebody and can identify that perhaps these are issues of codependency that they're struggling with. Just one little slide on treatment considerations. We're going to get into it in the next PowerPoint and in other readings and work that we're doing in this class. But the concept of abstinence versus harm reduction, how to decide which of these approaches is appropriate. We'll talk about various assessments and ways to determine this. Certainly a couple of factors to keep in mind are somebody's medical condition. Clearly, if somebody's in risk or at risk, then harm reduction may not be appropriate. Their level of functioning, psychological and psychiatric functioning, harm reduction requires to some degree a higher level of functioning in order to be able to engage in the work around moderation and so on, and that might not be possible with certain conditions. Support system is important. Harm reduction again requires a good support system around, as does abstinence, but sometimes an abstinent approach is in a more of a highly supervised, maybe residential facility where that support system is brought in if somebody doesn't have that, in outside of a more residential or inpatient setting. History, if there have been repeated attempts at harm reduction or moderation that haven't been successful, then it's often an indication that abstinence approach is a more appropriate one. Financial resources certainly to be considered. Some of these approaches are more costly than others, and insurance doesn't always, insurance might be a factor that dictates treatment in that regard. Clearly, the bottom line is motivation. And sometimes motivation does not mean people are volunteering for this. Sometimes motivation is imposed, as in mandated treatment. And we'll get into a discussion of mandated treatment. There's often been debate about whether mandated treatment is effective or not, and I think you'll find many opinions on it. My opinion is that mandated treatment can often be very effective. The work is in the clinical room to find ways to help somebody find their motivation for that treatment, and motivational interviewing was a great opportunity for that, and we'll certainly be talking about that more. So that's pretty much it. I'm happy to have had this opportunity to talk with you. There's my kitchen. Happy to have had the opportunity to chat with you about this, and look forward to more conversations.